Welcome. NSG 419 Study Section 1. Abnormalities associated with birth injuries. Introduction. In this study section, we will be discussing birth injuries. These are injuries caused by the forces of labor and delivery, or may result from physiologic and/or environmental factors. The contributory factors are big baby or large infant, breech presentation, forceful extraction, or inexperienced personnel. Learning outcomes. When you have studied this section, you should be able to identify birth injury, manage patients with birth injury. Birth trauma. Birth trauma is defined as an injury sustained by the neonate during the process of labor and delivery. It usually results from trauma sustained during a difficult delivery or secondary to obstetric manipulation of the foetus to allow for delivery. Parker 2005. Potential birth injuries. Soft tissue injury. Laceration examples: abrasion, bruising, fat necrosis, etc. Skull injuries. CEPHALHAEMATOMA, fractures, scalp laceration, may be through fetal scalp electrode, scalp abscess. Intracranial hemorrhage. Subdural, subarachnoid. Eyes injury. Subconjunctival and retinal hemorrhage. Fractures. Clavicle, facial bones, humerus, fat dislocation. Muscle trauma. Injuries to muscle can occur when it is torn or when its blood supply is disrupted. Torticollis. A contracted state of the cervical muscle producing torsion of the neck. Torticollis is also known as wry neck or twisted neck. The most commonly damaged muscle is the sternocleidomastoid muscle, the belt of the anterior shoulder, when the foetus assumes a vertex presentation, or during rotation of the shoulders, when foetus is being born by the breech. The deformity may be confidential, hysterical, or due to pressure on the accessory nerve, inflammation of the glands of the neck, or to muscle spasm. Manifestation: present as a small lump approximately 2 cm diameter over the sternocleidomastoid muscle on the affected side of the neck. The lump consists of blood and fibrous tissue and appears to be painless for the baby. Management: stretching of the muscle can be achieved by laying the baby to sleep on the unaffected side and by using muscle stretching. Exercising under the guidance of a physiotherapist, the swelling will resolve over several weeks. Nerve trauma. Facial and brachial plexus nerves are the most commonly traumatized, while spinal cord injury is very rare. Feeding difficulties are usually overcome by the baby's own adaptation, although alternative feeding position may help prevent the baby being malnourished. At times, this trauma to the facial nerve may result within weeks if the damage is mild, but may extend to months or years if the damage is severe. Sometimes, cosmetic surgeries may be required for severely affected babies. Brachial plexus. The brachial plexus comprises of a matrix of nerves located in the neck and shoulder that are formed by the nerve roots existing from the spine at the 5th to 8th cervical C5 to C8 and the 1st thoracic T1 vertebrae. The trauma to the plexus is thought to be due to excessive lateral flexion, rotation or traction of the head and neck during vaginal breech, birth, or when shoulder dystocia occurs. Despite interventions such as elective cesarean section, less traction force, and increased skill in maneuvers used to manage shoulder dystocia, its occurrence is relatively stable. Therefore, brachial plexus trauma has been more recently associated with the force exerted by the uterus. Possible trauma to the plexus ranges from oedema, hemorrhage, and tearing of the nerves in baby born at term. Types of trauma to the brachial plexus. There are 4 types of trauma using the NARACAS classification. Erb's palsy. Duchenne herb is as a result of trauma to C5 to C6, which leads to paralysis of the shoulder muscles, biceps, elbow flexors, and forearm supinator muscles. The baby's affected arm is limp, inwardly rotated, the elbow extended, and the wrist pronated. When C7 is traumatized, an extended Erb's palsy presents in which the finger extensor muscles are affected, resulting in wrist and finger flexion. Lomke's palsy. It presents when there is trauma to C8 to T1, where the shoulder and upper arm are unaffected, but the lower arm, wrist, and hand are paralyzed, resulting in wrist drop, no grasp reflex, and a claw-like appearance of the hand. An associated trauma to the cervical sympathetic nerves results in Horner syndrome. This presents with no sensation on the affected side, pupil constriction, and eyelid ptosis. Diagnostic evaluation of brachial plexus. All types of plexus trauma involve further investigations. These include X-ray and ultrasound scanning (USS) of the clavicle, arm, chest, and cervical spine, as well as assessment of the joints. Magnetic resonance imaging (MRI) and electromyography may assist in definite diagnosis, management of brachial plexus. Avoid unnecessary movement of the affected arm when holding or moving the baby to avoid arm dangling. Do not leave the baby by the arms or axilla. The affected arm should be dressed first and undressed last. Passive range of movement can be initiated under the direction of a physiotherapist after approximately 2 weeks when any inflammation should have been subsided. Regular functional follow-up assessments are essential to ascertain recovery. Most babies with brachial plexus trauma recover completely within 3 weeks. Babies with no recovery of biceps function by 3 months, as well as those with total brachial plexus injury with no recovery by 1 month, may be referred for surgical exploration and or require microsurgical nerve repair. Fractures are rare, but parts of the bone commonly affected are clavicle, humerus, femur, and the skull. As with all fractures, a crack may be heard during the birth of the baby. Clavicle. It is the most common fractures and may occur with shoulder dystocia, vaginal breech birth, and microsomic baby. The affected clavicle is usually the one nearest the maternal symphysis pubis. Further investigation are required to rule out brachial plexus, a phrenic nerve injury. It is possible to feel a distortion in the bone and crepitus or callus formation during an examination. Humerus. Mid-shaft fracture may occur if there is shoulder dystocia or during a birth by the breech when the extended arm is brought down and bone. Considerable deformity is evident on examination and baby will be reluctant to move the arm as a result of pain. Femur. Mid-shaft femoral fractures may occur during vaginal breech birth if the extended legs are forced down and bone. With most fractures, deformity, swelling, distortion, or bruising are usually evident on examination. Crepitus may be felt. The baby appears to be in pain and reluctantly move the affected area. An X-ray examination may confirm the diagnosis. Management of fractures. X-ray examination can be done to confirm diagnosis. Careful handling is very important, especially during cleansing and dressing, to reduce discomfort as the baby is likely to experience pain. The affected bone must be supported while carrying the baby. Mild analgesia like paracetamol may be appropriate. Positioning of baby on the back or on the unaffected side will be more comfortable and assist healing. Fractures of the clavicle require no specific treatment. Fractures of the humerus may require immobilization. This may be achieved by placing a pad in the axilla and splitting the arm to the chest with a bandage. Application should be firm but should not embarrass respirations. With fractures of the femur, immobilization of the leg is relatively easy using a splint or a bandage. Stable union of a fractured clavicle usually occurs in 7 to 10 days, while the humerus and the femur take 2 to 4 weeks. Immobilize a fractured action. Immobilize a fractured femur using a splint and bandage, but place a pad in the baby's axilla before using a splint and a bandage. Traction and plaster casting may be required. Clinical manifestations. Signs of associated complications such as intracranial hemorrhage, raised intracranial pressures, neurological disturbances, leakage of cerebrospinal fluid, or seizures can lead to the detection of a fracture of the skull. Management of skull fracture. X-ray examination can confirm the diagnosis. Linear fractures usually require no treatment. The pressed fracture may require surgical intervention. Antibiotic therapy is indicated if there is leakage of cerebrospinal fluid through the ear or nose. Treatment of the associated complication is necessary. Linear skull fractures usually heal quickly with no sequel or further complications. The pressed fractures will heal without much problem of complication have not occurred. Where complications have occurred, there may be permanent neurological damage. Hemorrhage due to trauma. Introduction. Blood volume in the term baby is approximately 80 to 100 milliliter or kilogram and 90 to 105 milliliter or kilogram in the preterm baby. Small hemorrhage can be potentially fatal. Causes of hemorrhage: trauma, disruptions in blood flow, coagulopathies, other causes. Hemorrhage due to trauma. CEPHALHAEMATOMA. This is an effusion of blood using the periosteum that covers the skull bones. There is friction between fetal skull and bones of maternal pelvis during vaginal birth. The periosteum is torn from the bone, causing bleeding underneath. A CEPHALHAEMATOMA is confined to one bone. Causes: it occurs during a vaginal birth with friction between the fetal skull and maternal pelvic bone. Results from cephalopelvic disproportion, precipitate labor, vacuum-assisted birth. The periosteum is torn from the bone, causing bleeding underneath. Because the fetal or newborn skull bones are not fused, the periosteum is adherent to the edges of the skull bones. Characteristics: a CEPHALHAEMATOMA is confined to one bone. However, when more than one bone is affected, multiple CEPHALHAEMATOMA may develop, not present at birth. Swelling appears after 12 hours and grows later over subsequent days and can persist for weeks. A double CEPHALHAEMATOMA is usually bilateral. The swelling is firm. It does not pit on pressure. It does not cross a sutured and is fixed. Management: no treatment is necessary. The blood is absorbed and swelling subsides. Hyperbilirubinemia may complicate the baby's recovery. Complication: hemolysis of the extravased blood may result in hyperbilirubinemia. A ridge of bone felt around the periphery of swelling is due to accumulation of osteoblasts. Subaponeurotic hemorrhage. This is rare and occurs as a result of excessive traction on veins that travel through a potential space above the periosteum, allowing for attachment of muscles. Epicranial aponeurosis. A sheet of fibrous tissues that covers the cranial vault. Causes: this is caused by excessive traction on the veins, which results in hemorrhage as the epicranial aponeurosis is pulled away from the periosteum of the skull bones and the swelling is evident. It may occur with any type of birth, but it is more often associated with vacuum-assisted births, primarious women, severe dystocia, occipitolateral or posterior head positions, preterm babies, precipitate births, macrosomia, coagulopathies, male babies. Clinical manifestations: the swelling is persistent at birth, increases in size, and is a firm fluted mass. The scalp is movable rather than fixed. The swelling can cross sutures and extend into the subcutaneous tissue of necks and eyelids. The baby experiences pain with the head movement or handling of the swelling. Management: it is an emergency situation requiring immediate medical assistance. Stabilization and full supportive care, including blood transfusion. Complications: excessive hemorrhage, shock, associated with 25% mortality rate. Hemorrhage due to hypoxia. Hemorrhage due to hypoxia are as follows: 1. Primary subarachnoid hemorrhage. 2. Parenchymal hemorrhage. 3. Periventricular or intraventricular hemorrhage. 4. Periventricular leukomalacia. Possible signs when observed are: generalized convulsion from the second day of life. Preterm babies may have apneic episodes. Some other babies may appear normal. May be difficult to observe using ultrasound scanning. Computerized tomography (CT) scanning can demonstrate the hemorrhage. Lumbar puncture will show uniformly blood-stained cerebrospinal fluid. Management. The condition will likely resolve on its own. Aims of management are to control of the consequence of asphyxia, control of convulsions, complications. Most hemorrhage hydrocephalus can complicate the baby's recovery. Drainage of the hydrocephaly is usually not required, and prognosis for recovery is usually favorable. Parenchymal hemorrhage. It is a hemorrhage into the cerebral tissue and is usually secondary to periventricular or intraventricular hemorrhage. Causes. Occur as a complication of birth, asphyxia, coagulopathies, or occasionally result from central nervous system malformations, considered to be a periventricular hemorrhage infraction. Diagnosis and management. Ultrasound scanning and computerized tomography scanning are used for diagnosis. Scan can also detect cystic cavities resulting from destruction of cerebral tissues. Both term and preterm babies may be affected and may signs of cerebral irritation and convulsions. Supportive care is required to reduce cerebral irritation and control convulsions. Periventricular or intraventricular hemorrhage. Most common and serious of all intracranial hemorrhages primarily affect infants of less than 32 weeks gestation and weighing less than 1,500 grams. Major risk factor is hypoxia around the time of birth or in the early postnatal period. Could occur secondary to birth trauma. Most of the multiple associated factors are experienced postnatally and affect cerebral hemodynamics. Pathophysiology. The level of brain development is an important factor in the etiology of periventricular and intraventricular hemorrhages, PVH or IVH. The lateral ventricles are lined with epidermal tissues. Tissues lying immediately next to the epiderma is the germinal matrix, sometimes also known as subepidermal layer. From 8 to 28 weeks gestation, the germinal matrix is responsible for producing cells, neuroblasts, which migrate to become the cerebral cortex. During this period, a rich blood supply is provided through fragile capillaries, which lack supporting muscle or collagen fibers. The vessels being vulnerable to hemodynamic changes and can rupture easily. After 32-week gestation, the germinal matrix becomes less and less active and by term has almost completely involuted. At the same time, the capillaries become more stable. Periventricular hemorrhage is known by 3 synonyms: subepidermal, germinal matrix, and grade 1 hemorrhage. If there is extension of the hemorrhage into the lateral ventricles, this is known as an intraventricular hemorrhage or grade 2 hemorrhage. The choroid plexus of the lateral ventricles normally produces cerebrospinal fluid CSF if there is blockage to the outflow of CSF. Post-hemorrhagic hydrocephalus will develop and the ventricles will dilate. This is termed a grade 3 intraventricular hemorrhage. Subepidermal hemorrhage can extend to the cerebral tissue, which results to a parenchymal hemorrhage, which is also known as a grade 4 hemorrhage. Clinical features. Small periventricular hemorrhage may have no clinical features. If extensive, the clinical features may include apnoeic episodes, which become more frequent and severe, episodes of bradycardia, pallor, metabolic acidosis, and convulsions. Screening and diagnosis. At risk, babies are usually screened within the first days of life for PVH or IVH using cranial US scan. If hemorrhage is detected, serial scanning can determine if there is any increase, extension, or complication. Management. Much of the care of the at-risk babies is focused on the prevention of PVH or IVH. The prenatal administration of steroids to the mother to stimulate the maturation of surfactants may also have a neuroprotective effect when prenatal steroids are followed by the administration of artificial surfactants postnatally. There is a reduction in the incidence of PVH or IVH. Hemodynamic stability remains the aim of the care and prevention of complications which the preterm can develop. Carefully assess and thoroughly meet the baby's need related to respiration and acid-base balance, circulation, temperature control, nutrition, and elimination. Prognosis. The outcome of PVH or IVH depends on the nature of the hemorrhage. The neurological prognosis for babies with grade 1 and 2 hemorrhages is usually good. Babies who suffer a massive grade 4 hemorrhage usually die within 48 hours of the onset. Those who survive are likely to develop convulsion, cerebral atrophy, and rapidly developing hydrocephalus. Will require long-term neurological follow-up, reader assignment, hemorrhage related to coagulopathies, convulsion. Now we've come to the end of study section 1. Thank you.